Okay, so morning everybody. This gets us to the next question in our subject-wise test pathology, that is question number 41. This gets us to the next question, that is question 41. So let us have a look at this, which is not seen in polycythemia vera. Increased vitamin B12 binding capacity, it is seen, but let's put a question mark, we are unsure about it. Increased erythropoietin, not at all, not at all. Polycythemia vera, it has a high hemoglobin with a reduced serum erythropoietin. This point is important. So even if you know about others or not, it is associated with a reduced serum erythropoietin. Increased RBC count and ocular congestion are its features. They are its features. So question 41, the answer is B, that is increased serum erythropoietin. Increased serum erythropoietin. This is not seen in PV. Next point. So starting with polycythemia vera. Starting with polycythemia vera, you know it is an MPN. It comes under the category of myeloproliferative neoplasms. It comes under the category of myeloproliferative neoplasms. There are four main MPNs, which are CML, chronic myeloid leukemia, PV, polycythemia vera, ET, that is essential thrombocytosis, and PMF, that is primary myelofibrosis. So there are four main MPNs. PV, it comes under MPN. It is a myeloproliferative neoplasm. Next point, criteria for making a diagnosis of PV. First point, it is associated with a high hemoglobin. Hemoglobin is elevated. How much? More than 16.5 grams per deciliter. More than 16.5 grams per deciliter in males, whereas more than 16 grams per deciliter in females. First point. Next, so suppose I have a patient whose hemoglobin is 20 grams per deciliter. Can I now safely say that it is a case of PV? No. So the second point is reactive causes of erythrocytosis. Reactive causes of erythrocytosis have to be ruled out. Reactive causes of erythrocytosis have to be ruled out. What do we mean by reactive causes? High altitude, smoking, smoking, COPDs, that is chronic obstructive pulmonary disorders, COPDs. Next, athletes. These are the reactive causes which are associated with a high hemoglobin. They have to be ruled out before we start considering blood cancers. PV is a blood cancer. How will we rule them out? These reactive causes, which is the main hormone responsible for erythropoiesis? Erythropoietin. So the reactive causes, the serum erythropoietin is increased versus polycythemia vera, extremely important, associated with a reduced serum erythropoietin. Associated with a reduced serum erythropoietin. PV is a blood cancer with high hemoglobin, which gives a negative feedback to the erythropoietin levels. As a result, the serum erythropoietin is reduced. The serum erythropoietin is reduced. Next point, PV, is it clonal or non-clonal? It is a blood cancer. All malignancies are clonal in nature. That is, they arise from the proliferation of the same cell. It is a clonal disorder. So if it is clonal, it would be associated with a mutation. And which mutation is seen in PV? It is the JAK2 mutation. That is a genus kinase 2 domain mutation. JAK2 mutation. Which JAK2 mutation? JAK2 has been asked 2 to 3 times. So let us go a step further. It is the JAK2 V617F mutation. JAK2 V617F mutation. What do we mean by this? It is a mutation in genus kinase 2 domain in which 617th amino acid, which is normally valine, is replaced by phenylalanine. I'll repeat, it is a mutation in phenylalanine. It is a mutation in genus kinase 2 domain in which the 617th amino acid, which is normally valine, is replaced by phenylalanine. This JAK2 V617F mutation This is seen in three MPNs, which are PV, ET, and PMF. It is seen in three MPNs, which are PV, ET, and PMF. But it is most commonly associated with PV, polycythemia vera, PV. Last point, bone marrow in polycythemia vera. Bone marrow. What sort of a bone marrow does it have? Is it hypercellular, normocellular, or hypocellular? It is a myeloproliferative neoplasm. So it has a hypercellular marrow. Hypercellular marrow with which is the predominant lineage. This is the point to be noted, with panmyelosis. With panmyelosis, that means all three lineages, the erythroid, the myeloid, and the megakaryocytic, all three lineages are proliferating. It is associated with panmyelosis. This finishes PV. Now, and an additional point is, we have already seen that PV is associated with reduced serum erythropoietin. Point to be noted here is, this is a minor diagnostic criteria. This is a minor diagnostic criteria in PV. This is not a major criteria. This is a minor criteria. Done. This takes care of question 41. This gets us to the next question, that is question number 42. This gets us to the next one, that is question 42. Most common cytogenetic change in MDS is deletion of chromosome 5. MDS, the answer is A. The answer is A, that is deletion of chromosome 5. Deletion of chromosome 5. So this starts us with MDS, myelodysplastic syndrome, MDS. First point, the peripheral smear in MDS is associated with pancytopenia. Let us see the salient features of MDS, myelodysplastic syndrome. It is associated with pancytopenia, with most commonly it has a hypercellular bone marrow. With most commonly it has a hypercellular bone marrow, but rarely the bone marrow can be hypocellular also. Most commonly it has a hypercellular bone marrow, but rarely it can be hypocellular also. First point. Next point, MDS, coming to its cytogenetic features. Cytogenetics in MDS. I'm not going to go into the details of classification here. I'm sure you already know that. So we have discussed it ample number of times in previous papers. So coming to the cytogenetics. The most common cytogenetics in MDS, most common cytogenetics is isolated deletion 5q syndrome. The most common cytogenetics in MDS is isolated deletion 5q syndrome. What do we mean by this? Each word is important. Isolated means this is the only abnormality. What? Deletion of long arm of chromosome 5. You very well know P for petite. Petite is the short arm, Q is the long arm. This is the most common cytogenetic abnormality. Next point, if it is the most common, is it good prognosis or poor prognosis? It is good prognosis. It is good prognosis. Next point, the poor prognostic abnormality in MDS. The poor prognostic abnormality. The poor prognostic abnormality in MDS is monosomy 7. The poor prognostic abnormality, monosomy 7. This monosomy 7, it is the most common cytogenetic abnormality in children. It is the most common cytogenetic abnormality in children. So I can safely say MDS in children has a poorer prognosis as compared to MDS in adults. That point is obvious. Next point, overall We have, which is the most common, which was overall the most common cytogenetics? Isolated deletion 5q. So this would be, this is most common overall, as well as this is the most common cytogenetics in adults. Both the points are similar. Why? Because MDS is more common in adults as compared to children. So whichever is the most common cytogenetic abnormality would be the most common abnormality in adults also. Isolated deletion 5q syndrome, which is associated with a good prognosis. Done. Next, this gets us to the next question, that is question 43. This gets us to question number 43. Hemans nephritis is a MGN, membranous glomerulonephritis. So coming to question number 43, the answer is B, that is MGN. Hemans nephritis, it is a MGN. So let us see more details of Hemans nephritis. Hemans nephritis. Hemans nephritis. Hemans nephritis. This is a slowly progressive. This is a slowly progressive immune mediated disease of the kidney. This is a slowly progressive immune mediated disease. Slowly progressive immune mediated disease. So it is associated with deposition of antigen antibody complexes. What is the site of deposit? The site of deposit in Hemans nephritis is subepithelial. It has a subepithelial deposit. Next point, immune mediated antigen antibody complex. So what is the antigen? What is the antigen? The antigen is Hemans antigen. The antigen in Hemans nephritis is Hemans antigen, called as Magellan, which is a 330 kilodalton protein. Hemans antigen, that is a 330 kilodalton protein, called as Magellan. Next point. This Hemans nephritis, this is managed with dialysis. This is actually not curable. But is managed with dialysis. It is not curable, but is managed with dialysis and immunosuppressive drugs. It is managed with dialysis and immunosuppressive therapy. This is Hemans nephritis. So the important point here was it is a membranous glomerulonephritis. The antigen is a 330 kilodalton protein called as Magellan, and the site of deposit was subepithelial. Next, this gets us to the next question, that is question number 44. That is question 44. Terminally differentiated stem cells of adult cannot proliferate. Terminally differentiated stem cells of the adult cannot proliferate like that of fetal cells, because the answer is C, that is CDK inhibitor. Let me slightly magnify it so that you have a better view. So the answer is C, because CDK inhibitors act at the S phase to prevent proliferation of adult cells. The answer is C. The adult stem cells, they cannot proliferate like that of fetal, because CDK inhibitor act at S phase to prevent proliferation of the adult cells. So this gets us to two important tables from neoplasia. First point is, let's start with the basics. Cell cycle you very well know has 5 phases, which are G0, G1, S, G2 and M. You also know that duplication of DNA takes place at the S phase. Next point, there are two checkpoints in the cell cycle. There are two checkpoints in the cell cycle, which are G1S and G2M. So checkpoints in the cell cycle, they are G1S and G2M. Next point, the checkpoints, they are crossed by cyclins binding to cyclin dependent kinases. How are the checkpoints crossed? By cyclins binding to cyclin dependent kinases. Cyclins, these are proteins which increase and reduce in a cyclical manner. So this gets us to the master table of cyclins with cyclin dependent kinases. There are two checkpoints, G1S, G2M. Whichever table we make in neoplasia, we start from the bottom. So the cyclin for crossing G2M is cyclin A and cyclin B. Cyclin A and cyclin B. Next point, cyclin C is not there. Cyclin D and cyclin E help in crossing G1S. Cyclins bind to cyclin dependent kinases. So again we start from the bottom. CDK21, CDK1. CDK3 is not there. CDK46, CDK2. An extremely important table which has been asked repeatedly. So let us see more questions associated with this. Which is the main checkpoint? G2M. The main checkpoint, G2M. Which is the main cyclin for crossing G2M? Cyclin A binding to CDK21. Next, I'm my mistake, I was slightly distracted, I'm so sorry. Please rephrase this point. The main checkpoint, let me write it for you, my mistake. The main checkpoint, kindly erase this is wrong, kindly let me get it back to this. The main checkpoint is G1S. My mistake, I don't know what I was thinking. So main checkpoint, G1S. The main cyclin for crossing G1S, cyclin D binding to CDK4. Cyclin D binding to CDK4. Next point, which is the main cyclin for crossing G2M? Cyclin B. Cyclin B binding to CDK1. So you know the main checkpoint G1S. I'll repeat this. Main checkpoint G1S, cyclin D binding to CDK4, D for Delhi, G2M, cyclin B, that is B for Bombay, binding to CDK1. This is how the checkpoints are crossed. In fetal stem cells, there is no inhibitor, whereas the adult stem cells, they cannot cross they cannot proliferate like the fetal stem cells because of the presence of CDK inhibitors, which prevents the proliferation. Next, this gets us to the next question, that is question number 45. This gets us to the next one, that is question 45. What we have here is a conventional cytogenetics or a karyotype showing there is one X, there is no Y. So this is 45XO, that is Turner syndrome. The question is, most specific feature of Turner's coarctation of aorta. So question 45, the answer is A, that is coarctation of aorta. So starting with Turner syndrome, you very well know Turner's is 45XO. So think of your favorite actress and imagine opposite of her, that is Turner's. So in Turner syndrome, the secondary female sexual characteristics are reduced. XO, one X is missing, so the secondary female sexual characteristics are reduced. So clinically, the patient has a short stature, low-webbed neck, short stature, low-webbed neck, widely spaced nipples, streak ovaries, cubitus valgus, that is the elbow is out, cubitus valgus, coarctation of aorta, and peripheral lymphedema at birth, These are the clinical features of Turner's. Easy to remember. So let us see more questions associated with these. First question, what happens to FSH and LH levels in Turner's? Low, normal, high. FSH and LH, they are increased because of streak ovaries. The hypothalamic pituitary axis tries to stimulate it. So FSH and LH are increased. Next point, another question that has repeatedly been asked with Turner's is, it is not associated with umbilical hernia. This again is important. Next point, IQ. Turner's, we know it very well. I mean, on a lighter mood, more are the number of X chromosomes, lower is the IQ. Easy to remember. So Klinefelter's, which has more number of X chromosomes, is low IQ, whereas Turner's is XO, so the IQ is normal. These are the other questions associated with Turner's. So the answer was coarctation of aorta. Next, this gets us to the next question, that is question number 46. This gets us to question 46. What we have here is the given type of pathology is seen in. You have the presence of classical asbestos bodies. So the answer is B, that is asbestosis. The answer is B, that is asbestosis. What it was showing you was the presence of asbestos bodies. So this gets us to the main topic in lungs, that is restrictive lung diseases. The main restrictive lung disease is pneumoconiosis. What is pneumoconiosis? It is the lung response to inorganic or organic matter. It is not necessary that it should only be inorganic in nature. This can be the lung response to organic matter also. There are three main pneumoconiosis, which are coal workers pneumoconiosis. There are three main ones, which are coal workers pneumoconiosis, silicosis, and asbestosis. So starting with the first one, that is coal workers pneumoconiosis, there are three main ones: coal workers, silicosis, and asbestosis. Starting with coal workers pneumoconiosis, first point, the particle in this is coal. The particle responsible for coal workers pneumoconiosis are the coal particles, obviously. So it is the occupation that it is associated with is coal mining. Next point, location. Coal workers pneumoconiosis, it most commonly affects the upper lobes. Of the lung. And the lesion associated with this is the presence of coal macules. The lesions associated with these is the presence of coal macules, which are 1 to 2 millimeters in diameter. And progressive massive fibrosis. It can also be associated with progressive massive fibrosis. which can be 1 to 10 centimeters in width, progressive massive fibrosis. Another point that is important in this is it is also associated with Kaplan syndrome. Co-workers pneumoconiosis, it is also associated with Kaplan syndrome. So what is Kaplan syndrome? It is rheumatoid arthritis. It is rheumatoid arthritis plus pneumoconiosis. Rheumatoid arthritis plus co-workers pneumoconiosis, that is Kaplan's syndrome. Next, so this was the first pneumoconiosis, co-workers pneumoconiosis. This gets us to the next one, that is silicosis. This gets us to the next pneumoconiosis, that is silicosis. Silicosis, it is associated with sandblasting. It is associated with sandblasting or stone cutting. Next point, the particles in silicosis. The particles, they can be of two types. They can either be the crystalline form or the amorphous form. Particles, they can either be the crystalline form or the amorphous form. Crystalline form, this is quartz. And this is more fibrogenic. Than the amorphous form. Next point, silicosis. Next point, location. It is associated with involvement of upper lobes of the lung again. So both co-workers pneumoconiosis and silicosis is upper lobes of the lung. Last point, it is the most common pneumoconiosis in the world. Which is silicosis. And the last pneumoconiosis is asbestosis. When I say the last, I mean the last and main important one, asbestosis, which of course is associated with asbestos particles. Which industry? It is associated with insulation industry. The wires, they have insulation, so insulation industry associated with asbestosis. Next point, it has two kinds of particles. The serpentine form, it is associated with two kinds of particles, the serpentine form and the amphiboleiform. Particles, they can either be serpentine or amphibolate in nature. Serpentine form is more common, whereas amphiboleiform is more pathogenic. Next point, asbestosis, microscopically extremely important, is associated with the presence of asbestos bodies. It is associated with the presence of asbestos bodies and ferruginous bodies. Microscopically, it is associated with the presence of asbestos bodies and ferruginous bodies. What are ferruginous bodies? Ferruginous bodies, these are fibers of asbestos. Coated with iron-rich material. What do we mean by iron-rich material? That is hemosiderin, that is ferritin and hemosiderin. This is a ferruginous body. And this was what was asked in the paper. So diagnosis, asbestosis. Done. So we have seen three main restricted lung diseases, the parts of pneumoconiosis, which was silicosis, coal workers pneumoconiosis, silicosis, and asbestosis. Next, this gets us to the next question, that is question 47. Question 47. Pig bodies stain positive for all of the following except, see, pig bodies, they are positive for ubiquitin, tau, and ALS50, but they are not positive for alpha synuclein. So answer to question 47, answer to question number 47 is B, that is alpha synuclein. Alpha synuclein. This is a factual question and has to be remembered. Now, what is Pick's disease? Pick's disease, this is progressive degenerative disorder. This is actually factual and has to be remembered. Pick's disease, this is progressive degenerative disorder. Progressive degenerative disorder of the anterior frontal. Disorder of the anterior frontal and temporal neocortex. Of the anterior frontal and the temporal neocortex. First point, Pick's disease, it is a progressive degenerative disorder of the anterior frontal and the temporal neocortex. Next point, Pick's disease, it is associated with the presence of Pick bodies. It is associated with the presence of Pick bodies, which are intracellular cytoplasmic inclusions. Pick bodies, they are intracellular, which are intracellular cytoplasmic inclusions. Intracellular cytoplasmic inclusions which stain for three things, that are tau, ubiquitin, and ALS50, which stains for three things, that is tau, ubiquitin, and ALS50. This was what was asked in the paper. This was what was asked. Tau, ubiquitin, and ALS50. Tau, the pig bodies are positive, but not for alpha synuclein. Next, let me slightly enlarge it. Next, this gets us to the next one, that is question 48. Cryoprecipitate, it contains all of the following except factor 9. So question 48, the answer is B, that is factor 9. Cryoprecipitate, it contains all except factor 9. So this gets us to the components of a blood bag. Starting with, we will see the salient features of each. What are the components of blood which we can make by whole blood and compartmentalize it. Starting with RBC concentrate. 1 unit of RBC concentrate increases the hemoglobin by 1 gram per deciliter. Next point, it increases the hematocrit by 3 to 5% or 1 to 3%. I am okay with both. Next point, RBC concentrate storage temperature. All of us as interns, when we go and take the RBCs, so increases the hematocrit, a better answer actually would be 1 to 3%. Let's not go up to 5. A better answer would be 1 to 3%. Next point, storage temperature. It is stored at 2 to 6 degrees Celsius. When we go to the blood bank, they are cold. They are not frozen, but they are cold. storage temperature 2 to 6 degrees Celsius. Next point, shelf life. Shelf life, it depends on the preservative used. Depends on the preservative. What do we mean by this? There are 4 main preservatives. ACD, that is acid citrate dextrose, whose shelf life is 21 days. Next, CPD, citrate phosphate dextrose, which is 28 days. Next, CPDA, citrate phosphate dextrose with adenine, which is 35 days, and the longest shelf life is SAGM, sodium adenine glucose mannitol, that is 42 days. ACD, CPD, CPDA and SAGM, the shelf lives are in multiples of 7. Next, so this was the first one, that is RBC concentrate. The next is platelets. Platelet concentrates. Platelet concentrates. I can get the platelet concentrates into 2 types. They can either be random donor platelets. That is, multiple people came. Suppose a patient had low platelet count because of dengue or whatsoever. His 4-5 relatives came and each gave 1 unit. That is random donor platelets or a single donor platelet. What do we mean by a single donor platelet? In a single donor platelet, this is platelet concentrate. This is platelet concentrate from a single donor. Obtained by apheresis. This is a single donor platelet. So let us see their features. First point, the difference between the two is single donor platelet, everything is multiplied by 3 to 5. So starting with volume, random donor platelet is 50 to 70 ml versus a single donor platelet whose volume is 200 to 300 ml. Next point, they increase the platelet count. A random donor platelet by 10,000 per microliter, one bag, increases the platelet count by 10,000 versus a single donor platelet which increases by 30 to 50,000 per microliter. Next point, storage temperature. The storage temperature and shelf life for both would be similar, obviously, because platelets, they are kept at room temperature 20 to 24 degrees Celsius and they have a shelf life of 5 days. Easy to remember. Anything that is kept outside which is not in the fridge will decay after 5 days. So shelf life of 5 days. These are the platelets. Next, coming to the last two, which are the main ones, that is FFPs. So starting with FFP, fresh frozen plasma. FFPs, that is fresh frozen plasma. The name tells you everything. Frozen. It is stored at so the storage temperature is minus 30 degrees Celsius. If it is in a deep freezer, the shelf life would be much higher, that is 1 year. Fresh, it is freshly collected and then frozen. So plasma from a single donor is frozen within 6 hours of collection. It is frozen within 6 hours of collection. So fresh 6 hours, frozen minus 30 degrees and shelf life is 1 year. Next point, what is it rich in? FFPs, fresh frozen plasma, they contain all coagulation factors. And fibrinogen. But but they are relatively deficient in factor 5 and 8. This needs to be remembered. They are relatively deficient in factor 5 and 8. So coming to the indications of FFPs, they are all the coagulation factors, they are synthesized in liver. So liver diseases, because in those we need the coagulation factors. DIC, TTP, hemophilia. Which hemophilias? Will give it in both A and B, but they are mainly indicated in hemophilia B. A is deficiency of factor 8, B is deficiency of factor 9. It is relatively deficient in factor 8, so they are not preferred in hemophilia A. But if cryoprecipitate is not available, then we can give it. So the last is cryoprecipitate. The last component is cryoprecipitate. Cryoprecipitate. I guess this was what was asked. Cryoprecipitate. Cryoprecipitate. These contain precipitated proteins from FFP. These contain precipitated proteins from fresh frozen plasma. They have precipitated proteins. So they are rich in fibrinogen, factor 8. FFP was deficient in 8. This is rich in factor 8, factor 13 and von Willebrand factor. This is important. What all things cryoprecipitate is rich in. So this again cryo, so minus 30 degrees Celsius 1 year. I am not even writing it. Next point, indications. It is used in von Willebrand disease, hemophilia A. This is preferred in hemophilia A because it is rich in factor 8. Factor 13 deficiency, and fibrinogen deficiency. These are the indications of cryoprecipitate. Done. So coming back to the question, cryoprecipitate contains all except factor 9. Next, this gets us to the next question, that is question 49. This gets us to the next one. In mitral valve prolapse, the histological finding is myxomatous degeneration of the valve. Question 49. The answer is C. Question 49. The answer is C. That is myxomatous degeneration. Of the valve. It is associated with mitral valve prolapse. It is associated with myxomatous degeneration of the valve. So mitral valve prolapse, MVP. Mitral valve prolapse, it is also called as systolic click murmur syndrome. It is also called as systolic click murmur syndrome, or the Barlow's syndrome, Next point, not interested. This is majorly a medicine topic. All I am interested in this is microscopically it is associated with myxomatous degeneration of the valve. Next point, which are the valves affected? It is the myxomatous degeneration. It is confined to the mitral valve. Most common valve affected, mitral valve. Rarely, however, tricuspid, or aortic valves. Tricuspid or the aortic valves may also be affected, but the most common is the mitral valve. Next point. Another point that was mentioned in the question was fibrinoid necrosis. Fibrinoid necrosis. Extremely important. The diseases associated with fibrinoid necrosis. Extremely important. The diseases associated with fibrinoid necrosis. They are malignant hypertension, malignant hypertension affecting the kidney, malignant nephrosclerosis. Next is lupus, SLE, SLE affecting the kidney, called as lupus nephritis, or SLE affecting the heart, that is Libman-Sack endocarditis. SLE affecting the heart, that is Libman-Sack endocarditis. Next, RHD, rheumatic heart disease. Next, vasculitis. Which vasculitis? PAN. Now, PAN, polyangiitis nodosa, you know it is a medium vessel vasculitis. It has two phases, an acute phase and a chronic phase. So, which phase of PAN? Acute phase. PAN, acute phase. Why? Because fibrinoid necrosis, it is a more aggressive entity affecting the acute phase of PAN. And the last point in fibrinoid necrosis is it is also associated with graft rejection. Also associated with graft rejection. Now, graft rejection, it has three phases: a hyperacute phase, an acute phase, and a chronic phase. Which phase of graft rejection? A hyperacute phase. A hyperacute phase. These are the diseases associated with fibrinoid necrosis and have to be remembered. Next, this gets us to the next question, that is question number 50. This gets us to the next one, that is question 50. What we have here is the presence of hepatocytes. Even without looking at the options in this, I can make out that it is showing you the presence of hepatocytes with a cell with an arrow. This cell, it is smaller in size as compared to the surrounding hepatocytes, making this as an apoptotic hepatocyte. And apoptotic hepatocyte is called as Councilman body. Councilman body. So now let us see the question. Following type of body is characteristically seen in. So what the examiner is asking you is, Councilman bodies are seen in, and the answer is C, that is acute viral hepatitis. Councilman bodies, they are seen in acute viral hepatitis. They are seen in acute viral hepatitis. So before we go further, let us see the microscopic features of acute hepatitis. Microscopically, acute hepatitis, it is associated with, first point, the most common change is ballooning degeneration. In acute viral hepatitis, the most common change is ballooning degeneration. Other features are, it is also associated with apoptosis of hepatocytes, which are called as Councilman bodies. This was what was given in the image, Councilman bodies. Next, it is associated with the mixed inflammatory infiltrate. Mixed inflammation matlab it can be anything, neutrophils, lymphocytes, monocytes, a mixed inflammatory infiltrate. The macrophages increase in number. Macrophages in the liver are called as Kupffer cells. So Kupffer cell hyperplasia, and the last point is cholestasis. So acute viral hepatitis microscopically is associated with these features. Versus chronic hepatitis, which is associated with three main microscopic features, which are bridging fibrosis, which are bridging fibrosis. Bridging fibrosis means liver has two big areas, portal tract and central vein. So bridging fibrosis means portal tract to portal tract, central vein to central vein, or portal tract to central vein. Bridging fibrosis. Next, it is also associated with the presence of ground glass hepatocytes. Extremely important. Ground glass hepatocytes, most commonly seen in chronic hepatitis B virus infection. This has been asked repeatedly. Ground glass hepatocytes. And the last point is it is associated with piecemeal necrosis. Piecemeal necrosis. So chronic hepatitis, three features: bridging fibrosis, ground glass hepatocytes, and piecemeal necrosis. Piecemeal necrosis, this is necrosis of the limiting plate. This is necrosis of the limiting plate. And what is limiting plate? It is first layer of hepatocytes. Limiting plate, it is the first layer of hepatocytes present adjacent to the portal tract. Present adjacent to the portal tract. Matlab around the portal tract, the first layer of hepatocytes that are present is the limiting plate. And necrosis of the limiting plate is piecemeal necrosis. Done. These are the features of acute and chronic hepatitis. Next. So this gets us to the next question, that is question 51. This gets us to the next one, that is question 51. Which of the following is not an X-linked condition? Duchenne's muscular dystrophies, both the muscular dystrophies, Duchenne's as well as Becker's, are X-linked. Next, Emery-Dreifuss muscular dystrophy is also X-linked, but facioscapulohumeral muscular dystrophy is not. So the answer is C. The answer is C. That is facioscapulohumeral. Facioscapulohumeral muscular dystrophy. This is not X-linked in nature. This is autosomal dominant. This is autosomal dominant. This is to be remembered. This is to be remembered. This is factual. So before we go further, this gets us to the X-linked recessive and the X-linked dominant conditions. So starting with the X-linked recessive diseases. Starting with the X-linked recessive diseases, they are the muscular dystrophies. The muscular dystrophies, that is the ones which were mentioned in the options, Becker's, Duchenne's and stuff, X-linked recessive, versus facioscapulohumeral, which is autosomal dominant. Next muscular dystrophies. Next, hemophilias. Easy to remember, we write hemophilia as XH. It is X-linked recessive. Next, chronic granulomatous disease. Chronic granulomatous disease, we have seen this in detail in this paper only. It is a disease of innate immunity, X-linked recessive in nature. Next, G6PD deficiency. Glucose 6-phosphate dehydrogenase, G6PD deficiency. Next, color blindness. Color blindness, this again has been repeatedly asked, so I am putting a star on this. And Wiskott-Aldrich syndrome has to be remembered. Wiskott-Aldrich syndrome. These are the X-linked recessive conditions. Versus X-linked dominant. Versus X-linked dominant diseases, which are three, which are Alport's syndrome, X-linked dominant, which are Alport's syndrome. Next, hypophosphatemic rickets. Hypophosphatemic rickets, or the vitamin D deficient rickets. And the last is Charcot-Marie-Tooth disease. and the last is Charcot-Marie-Tooth disease. These are the X-linked dominant diseases. These are the X-linked dominant diseases. Done. So this takes care of question 51. This gets us to question number 52. This gets us to question 52. Zellbellen pattern is found in, and the answer is A, that is pheochromocytoma. Zellbellen pattern, we have already seen this in detail. It is found in pheochromocytoma. It is found in pheochromocytoma. So before we go further, let us have a look at few features or few points with pheochromocytomas. Pheochromocytomas, they are a neoplasm. They are a neoplasm composed of chromaffin cells. They are a neoplasm composed of chromaffin cells. Next point, which synthesize and secrete catecholamines. Which synthesize and secrete catecholamines. Next point, pheochromocytomas, they follow the rules of 10. They follow the rules of 10. That is, the first point is they are familial in 10% of the cases. 10% of the cases are familial in nature. When I say familial, which familial syndromes? The MEN2 syndromes, both MEN2A and MEN2B. The MEN2 syndromes, neurofibromatosis type 1, and von Hippel-Lindau syndrome. Neurofibromatosis type 1 and von Hippel-Lindau. So the first rule of 10 is in 10% of the cases they are familial. Next point, in 10% of the patients they are extra-adrenal in nature. They are extra-adrenal, they occur outside the adrenal gland, with the most common being at the organ of Zuckerkandl. Most common being at organ of Zuckerkandl. Organ of Zuckerkandl. Next point, in 10% of the cases they are bilateral. In 10% of the cases they are bilateral, and 10% are malignant in nature. 10% are malignant in nature. So pheochromocytomas, they follow the rules of 10. Microscopically, they are composed of polygonal or spindle shaped chromaffin cells. Polygonal or spindle shaped chromaffin cells, which are compartmentalized into small nests. Which are compartmentalized into small nests. This compartmentalization is called as Zellbellen pattern. And how are they compartmentalized? By a rich vascular network. They are compartmentalized by a rich vascular network, and this compartmentalization is called as the Zellbellen pattern. This compartmentalization is called as the Zellbellen pattern seen in pheochromocytomas. So before we go further, let us have a look at what it looks like microscopically. Let us see what it looks like microscopically. Just a sec. We have already seen the photograph of Zellbellen. I don't know why I'm not able to find it at present. Just give me a sec. Okay, So this is the Zellbellen pattern seen in pheochromocytoma. What we see here is the presence of polygonal cells in nests which are compartmentalized by a rich vascular network. These are the compartments. See, these are the vessels. These are the compartments that the vessels are making. This is the classical Zellbellen pattern. This is the classical Zellbellen pattern seen in pheochromocytoma. Next, this gets us to the next question, that is question number 53. This gets us to the next question, that is 53. In Glanzmann's thromboasthenia, there is a defect in platelet aggregation. The answer is A, that is platelet aggregation. In Glanzmann's thromboasthenia, it is a defect in platelet aggregation. What do we mean by this? So, coming to the steps in a primary hemostatic plug, let us see this slightly in more detail. Coming to the steps of primary hemostatic plug formation. Primary hemostatic plug, it has 3 steps, which are platelet adhesion. It has 3 steps, which are platelet adhesion, platelet activation, and platelet aggregation. So primary hemostatic plug formation, it has 3 steps. Platelet adhesion, it is mediated by von Willebrand factor binding to GP1B. Von Willebrand factor binding to GP1B, which in turn leads to a change in shape of platelets and release of granules, in turn leading to platelet aggregation, which is mediated by binding of GP2B3A, with fibrinogen. So there are 3 steps: platelet adhesion, activation, and aggregation. Next point, there are 3 diseases associated with this. First is the von Willebrand disease. Next, defect in GP1B, which is associated with Bernard-Sollier syndrome, BSS, that is Bernard-Sollier syndrome. And the last is defect in GP2B3A. Which is a defect in platelet aggregation, which is associated with Glanzmann's thromboasthenia. So this is primary hemostatic plug formation. This is what we mean by primary hemostatic plug formation: platelet adhesion, activation, aggregation, 3 diseases associated. Glanzmann's is a defect in platelet aggregation. Next, this gets us to the next question, that is question number 54. This gets us to the next one, that is question 54. 54 male biopsy, hepatitis B infection, multiple Councilman bodies. Electrophoresis was done. Identify the pattern. See, in this question, the examiner had given you many hints. He had given you numerous hints. Not needed. Suppose the gel electrophoresis picture comes without any history. What you see here is the classical step ladder pattern. You are able to see the breaks, the classical step ladder pattern which is seen in apoptosis. The rest of the points of the question, that is Councilman bodies, which are the apoptotic bodies of the hepatocytes, again makes it apoptosis, but in the paper so many hints would not be given. So this gets us to the, so firstly the answer is A. The answer is A, that is step ladder pattern. The answer is A, that is the step ladder pattern seen in apoptosis. Seen in apoptosis. So this gets us to the gel electrophoresis picture. What we see in gel electrophoresis, this is the gel electrophoresis. This is the point of application. This is the point of application. Point of application means we have applied the sample there. What we see in necrosis is a diffuse smearing pattern. Necrosis shows the presence of a diffuse smearing pattern. It is diffuse smearing that we see. So necrosis shows diffuse smearing versus apoptosis. Apoptosis, the break is occurring at specific points. So the endonucleases, they act at specific points, showing the classical step ladder pattern. Apoptosis shows the classical step ladder pattern. It shows the classical step ladder pattern. Next is normal DNA. Normal DNA. DNA, it would be heavier than most because DNA only breaks into necrosis and apoptosis. So DNA, we see the presence of a thick discrete band close to the point of application. DNA versus RNA, in which we see two bands which migrate slightly away from DNA but are still close to the point of application. So DNA and RNA. This is the gel electrophoresis picture, which is seen with various conditions. Next, so this gets us to the next question, that is question number 55. This gets us to the next question, that is question 55. What you see here is 50 female underwent cholecystectomy. Gallbladder is seen infiltrated with foam cells. Gallbladder is seen associated with foam cells. So what we have here is the presence of all these foam cells, making the answer simply as cholesterolosis. So question 55, the answer is A, that is cholesterolosis. In the question given, they had also mentioned foam cells. Even if it was not mentioned and you just had the image, you are able to see presence of numerous foam cells in this, making the answer as cholesterolosis of the gallbladder. Next,